Hello, everyone. It's a very warm welcome from my side. I'm Dr. Nitin Abhyankar from Pune. And let me at the onset thank Indian Chess Society, our president, Dr. Sandeep Salvi, Dr. Amita Nene, who has been the mastermind behind this brilliantly run series of talks. And I think we have crossed 12 of them with more than 1,500 plus logins. And of course, Dr. Raja Dar, our secretary of the Indian Chess Society, for doing this brilliant job of obstructive airway disease related webinars. And I also thank the entire Lupin team for backing us, including Hirak and Raja and everybody else. So with that, let me introduce today's topic. We are having a very exciting acronym called TOPD, the unknown enemy. The T stand obviously for tuberculosis. And who really thought, when I started my residency days, and I wanted to be an interventional pulmonologist. And I said, I'll do everything else but tuberculosis. And today, I am moderating this webinar, and I have a talk tomorrow in the Research Society in BSA on National Tuberculosis Program. So that's our destinies. So I think that's the whole story, that tuberculosis has never gone away from our scenario in the complete way. It'll take us a lot of effort and a lot of time, but at the same time, today, what we are going to focus on is tuberculosis-related obstructive pulmonary disease. And who else but Dr. Vishwesh? Can I have his biodata, please, on the slides? Dr. Vishwesh is from Hyderabad. He's one of the very young, but at the same time, extremely sorted out kind of pulmonologist, so Vishwesh Balasubramaniam. He's in both IP as well as in sleep in Yashoda Hospital in Hyderabad. He's a DM in pulmonary and critical care, a gold medalist from Safdarjung Hospital, New Delhi. He has done fellowship in advanced interventional pulmonology in Malaysia and in sleep medicine. And of course, like me, he is a European diplomat in adult respiratory medicine. He's got around 30 publications in international and national journals. He is a course director for advanced interventional pulmonology at Yashoda Hospitals. He's a reviewer for Lung India, which is our go-to journal at this point in time. He's a member of Executive Committee for Nebulizations and Guidelines in India. He's a program director for Pulmomentor and IP Mentor for annual international pulmonary conferences, and is also selected as one of the top pulmonologists across the country by Economic Times. Very dear friend Vishwesh will talk to us in brief about tuberculosis related obstructive pulmonary diseases, and then we will introduce our panel, which is going to be, well, icing on the cake. So let's go to Vishwesh's talk.
Good evening, seniors and friends. At the outset, I'd like to thank Dr. Amita Nene for giving this opportunity to speak on post-tuberculous obstructive airway disease, which we refer to as the TOPD. So we all know that the TB can present with a lot of sequelae in the lung, which we refer to as the post-TB lung diseases. So these post-TB lung diseases, or the PTLD, can result either in the scarring of the lung along with the structural lung damage, or it need not cause permanent scarring in the lung, but it can cause in the airways and can still lead to structural damage, which can manifest as TOPD. If we move into the spectrum of the post-TB sequelae of the lung, it can affect your airways, it can affect your parenchyma, pleura, and pulmonary vasculature. When it affects the airway, we have the classical one, which we refer to as the TOPD, or the tuberculosis-associated obstructive lung disease, where primarily it causes an airway obstruction as evidenced by an FE1 by FEC ratio less than 0.7 or less than lower limit of normal value, primarily related to the tuberculosis-associated lung disease. In addition to this TOPD, it can also affect the airway and cause bronchiectasis, where there is an evidence of an airway dilation which is greater than the diameter of the adjacent vessels. Apart from this, the TOPD can coexist with the sequelae that are affecting the parenchyma. Like you can have a TOPD with a cavitary fibrocavitary disorder, or you can have a TOPD even with a parenchymal destruction or a fibrotic change, or even for that matter, an aspergilloma. Sometimes TOPD can coexist along with the chronic pleural disease, as evidenced by the post-tubercular pleural thickening on an X-ray or CT scan. And generally, TOPD patients in association with the structural lung damage can also have pulmonary vascular disorders. So TOPD is primarily a diagnosis based upon your clinical history, where you have a history of tuberculosis, and diagnosed with the evidence of a spirometry, where you demonstrate an obstruction FE1 by FEC less than 0.7 or lower limit of normal value, and you have ruled out a possibly alternative etiology for an obstructive airway disorder. So you can have a myriad of presentation of the tuberculosis as a sequelae. Like you can have a cavitary, as you can see from here. You can have architectural distortions. You can have bronchiectasis. You can have a completely destroyed lung. But generally, TOPD, when we say, generally have some element of an airway involvement, as evidenced by either a bronchiectatic changes, or sometimes you can have extensive air trapping because of small airway disorders. So what essentially happens in a TOPD? So there is a structural damage. Depending upon the varying degree of scarring, you can have an obstruction of the airway, which can be either a small or a large, and it can manifest as either a bronchitis if it is a large airway, or a bronchiolitis and a bronchiectasis. In addition to this, in the parenchyma, as we have seen, it can cause fibrosis, fibrocavitary sequelae, pleural and chest wall damage, and sometimes you may not find a classical obstruction alone, because there can be a mixture of an obstruction and a restriction. And that is where probably your symptoms as well as your IOS can come into a play in picking up these small airway disorders in these patients. And when there is a no structural lung damage, it is difficult to pinpoint the development of an obstructive airway disease due to the altered immunity. And sometimes you can find that the patient has got a history of endobronchial tuberculosis, and sometimes when it is not managed properly, it may not show evidence of any structural damages in the lung, but in PFT, the patient may still have an obstructive pattern which can fit into the criteria of a TOPD. So if we move to the GOLD criteria, so COPD is defined as a heterogeneous lung condition, which is characterized by chronic respiratory symptoms like a dyspnea, cough, sputum production, or an exacerbation due to the abnormalities of the airways, which can manifest as bronchitis or the bronchiolitis, and or alveoli, which causes emphysema, that causes persistent, often progressive airflow limitation. So if you change the COPD as TOPD, you will find that all these conditions, all the parts of the definition will fit into a case of TOPD as well. For example, in TOPD, you will have dyspnea, you will have cough. If TOPD is associated with bronchiectasis, you can have sputum production, you can have recurrent exacerbation because of the structural lung disease. And it affects not only the large airways and manifests as bronchitis, it can affect the small airways causing bronchiolitis. And sometimes there can be an extensive destruction of the alveoli because of an air trapping by bronchiolitis, and it can cause emphysema. And generally, the TOPD is persistent because it's a permanent damage, and it is generally progressive. The only difference is it is not as often progressive as your COPD, because it is a one-time hit. But if a patient is going to have a recurrent infections, then it can still be a progressive disorder, and it is associated with an airflow limitation. So that is why now, unlike the past, the COPD also, the GOLD has clearly said that you need to classify the COPD depending upon the etiology. For example, if it is because of your genetics, like an alpha-1 antitrypsin, you call it a COPD-G. If it is because of a developmental lung disorder, we'll call it as the COPD-D. And the most common one is the cigarette smoking, which we refer to as the COPD-C. Sometimes the COPD can be because of a biomass or a pollution-related exposure, which we refer to as the COPD-P. And what we are concerned today is the COPD due to infections. And one common infection that is found in India is the tuberculosis. Therefore, it is called as a COPD-I. So, but if it is just because of tuberculosis, then this nomenclature becomes a TOPD, that is tuberculosis associated lung airway obstruction. And in addition, COPD can be coexistent with asthma. So why patients with tuberculosis develop a lung disorder. So if we go into the growth development of the lungs and the airways. So in the birth, there is an alveolar which gradually increases as the age increases. And there is also, and your peak FEV1 is attained by the age of 20 years. But let's say that unfortunately the patient develops in tuberculosis much early in the age group before the 20 years of age. Therefore, it can affect your alveoli, it can affect your further division and growth of alveoli. Therefore, it will cause premature fall in your lung functions, making the patient prone to develop TOPD or the tuberculosis associated airway obstruction. But sometimes, let's say that the TB occurs beyond 20 years, by the time you already developed the full potential of your FEV1, but still it can cause residual scarring and can cause symptomatic respiratory illness. So if you move into the epidemiology, we cannot clear-cut say that these many number of the patients are TOPD because the diagnostic algorithm is evolving, and initially most of these patients were labeled as a post-TB sequelae. And studies also do not talk about whether it is scarred lung versus a non-scarred lung. And generally, if you see, tuberculosis also occurs amongst patients who are smokers. So you really don't know whether the obstructive airway disease is primarily because of the tuberculosis or it is caused because of the smoking, which is a confounding factor. And sometimes the patient can have a TOPD, fitting into the criteria of TOPD with a history of tuberculosis and an obstructive airway as evidenced on PFT. But sometimes you can have a confounding factor like the patient may be exposed to a biomass fuel or a pollution, or the patient could have had an intercurrent childhood infections because both tuberculosis as well as the other infections are common in childhood, or there can be an associated developmental lung disorders or a low vitamin D3 levels or an immunodeficiency, which means that it is very hard to say that your tuberculosis alone contributed to the obstructive airway diseases because we need to rule out all these confounding factors. So there is a second Korea National Health and Nutritional Examination Survey of 2001, which analyzed the effects of the previous tuberculosis on the risk of developing obstructive lung disease. So a total of 294 subjects had evidence of a prior tuberculosis on a chest radiograph. And after adjustment for their sex, age, smoking history, radiological evidence of previous tuberculosis was independently associated with an airflow with an odds ratio of 2.56, which clearly established that tuberculosis is a risk factor for developing an obstructive airway disease. And this risk was present even in patients with a minimal radiographic changes. And this is more so for patients who has got an endobronchial involvement with tuberculosis. Therefore, that is why it is of paramount importance to identify endobronchial tuberculosis, because if you don't identify and treat it properly, these patients can develop a permanent airflow limitation fitting into the criteria of TOPD. In addition to this, the Platino study also evaluated the relationship between the past history of tuberculosis and the development of airflow limitation in 5 Latin American countries. And they found out that the overall prevalence of the airflow obstruction was 30.7% among those with a history of tuberculosis, compared with 13.9% on those without a history of tuberculosis, with an odds ratio of 2.33 after excluding the confounders, which clearly means that even in the Latin American study, the tuberculosis is associated with a more odds ratio of developing an obstructive airway disease, which of late we refer to as a COPD-I or the COPD related to the infection, and infection in this case is tuberculosis. The risk is also found to be higher in males than in females with an adjusted odds ratio of 3.99 and 1.71 respectively. But this is little interesting because we find endobronchial tuberculosis to be more common in females than in males. On the contrary, your TOPD is found to be higher in males than in females. And one of the reasons that can be attributed is a high incidence of smoking amongst males in comparison to the females, and higher incidence of tuberculosis in the males in comparison to the females in certain population. So a systematic review was done to find out the association between the tuberculosis, pulmonary tuberculosis, and the development of the chronic airflow limitation in adults. So in this, they took 19 studies, which included case series, case control studies, cohort studies, single center cross-sectional and multi-center cross-sectional studies. And they tried to report a positive association between the tuberculosis and the airway obstruction. And they found out that there was a significant association between the tuberculosis, pulmonary tuberculosis, as well as the significant airway obstruction, indicating that the tuberculosis is a risk factor for developing an obstruction. So the study concluded that the systematic review confirms the evidence of a positive association between a past history of tuberculosis and the presence of airway obstruction. And this association is independent of cigarette smoking. Therefore, which means that even if you don't have a history of smoking or a biomass fuel exposure or other developmental disorders, if you have a history of tuberculosis, you are more prone to develop this tuberculosis associated pulmonary uh, tuberculosis associated pulmonary disorder, or the TOPD. So there is another study which was published in the European Respiratory Society. So 100 fully treated pulmonary tuberculosis patients in a tertiary teaching center in India, where 46% prevalence of airflow obstruction and prevalence increases after the duration, increases in duration after the treatment completion. So, which means that even in India, which is where we have the maximum burden of tuberculosis, therefore we tend to find more evidence of a tuberculosis associated obstruction in comparison to the other countries. And here they classified the airway obstruction as mild, moderate, and severe depending upon the FEV1. And they found out that more majority of the cases were in the mild zone, where the FEV1 was more than 60%. But 10% of the study population had a moderate airway obstruction, where the FEV1 was between 40 to 59%, and 15% of the patients had a severe airflow limitation, where the FEV1 was less than 40%. But one important thing this study lacked to find is that they did not comment upon the scarring or the non-scarring or the confounders, because these tuberculosis patients could still be a smoker or could still have had exposure of a biomass fuel. So how does tuberculosis really cause TOPD? So tuberculosis can affect any part of your lung, as we have seen already. And with respect to the airways, it causes obstruction of either the small airways, or it can cause the obstruction of the large airways. When it causes the obstruction of the small airways, it manifests as the bronchiolitis. And when it causes the obstruction of the large airways, it causes the bronchitis. And sometimes because of recurrent infections, it can lead to bronchiectasis. And this persistent inflammation followed by infection causes the triggering of the matrix metalloproteinases, which causes the destruction of the extracellular matrix and therefore brings about a chronic airflow limitation. So the pathophysiology is almost similar to that of a cigarette smoking associated COPD, but there are certain characteristics of TOPD which differ from the COPD. Like in TOPD, since it is caused only by tuberculosis, it tends to be a lung limited phenomenon. Whereas in COPD, because of nicotine, which has got a systemic absorption, your COPD patients related to the smoking can also have other harmful effects of nicotine, like they can develop higher incidence of coronary artery disease, or they can develop a higher incidence of CVA, or they can develop higher incidence of peripheral vascular disorders. But however, with respect to the lung cancer, both TOPD and COPD are at a higher risk of developing lung cancer, because TOPD, because of the scar carcinoma, can develop into a later adenocarcinoma as well. So the pathology is that it causes an accelerated tissue destruction by the matrix metalloproteinases. And this matrix metalloproteinases are a common mediator that may connect both the disorders of small airway obstruction as well as bronchiectasis. And various antimicrobial agents, for example, rifampicin, moxifloxacin, and azithromycin, showed an immunomodulatory effect by decreasing the epithelial gene expression and secretion of matrix metalloproteinases. And that is why initiation of an ATT very early in the course of the disease can bring about a reduction in the inflammatory process and the sequelae of the inflammation, which can manifest as a post-TB sequelae. So with moving on to the pathophysiology, the Th1 and Th2 subgroup of the lymphocytes regulate the development of the tuberculosis and bronchial asthma. And Th1 and Th2 levels are not enhanced simultaneously. And after anti-tubercular treatment, the enhanced levels of the Th1 come down, and a proportion of a patient develop Th2 mediated airway obstruction, which on aggravation emerges as bronchial asthma. So this is why you will feel like certain patients who are treated for tuberculosis later in the course of illness, they say that they have an asthmatic-like symptom, and that is because of an augmentation of the Th2 mediated airway obstruction. So to put it in a nutshell, when the tuberculosis affects your alveoli, it causes interstitial spread and granuloma formation, and sometimes it causes an exuberant inflammation and extensive granuloma formation. All these things results in extensive fibrosis, leading to TOPD, and certain cases it can also lead to emphysema. And with respect to the phenotyping of the TOPD and the COPD, hemopsis was more common in TOPD patients compared to the COPD patients, because we very well know that the TOPD tend to have higher incidence of post-infectious bronchiectasis, which leads to higher incidence of hemopsis. But however, few studies observed that there is no significant difference in the dyspnea or the cough exacerbation and the hospitalization between these two groups. And patients of TOPD also had a significantly lower FVC. That is because they also tend to have certain amount of parenchymal scarring and a post-dilator FEV1 value compared to those of COPD. The post-dilator FEV1 tends to be lower in TOPD because it is more of a permanent structural airway disorder. And the positive bronchodilator response was significantly lower in TOPD than in COPD, indicating the irreversible nature of airflow limitation. That is why probably when you give bronchodilators to a patient with a TOPD, they may respond less in comparison to your TOPD patients, in response to your in comparison to your COPD patients, because in TOPD there is an irreversible airway obstruction. So few studies also tried to identify what is the autoantibody and the immune group variations in the TOPD group. So they took healthy controls, they took COPD, they took TOPD, and they found out that the FEV1 by FEC was significantly lower in the TOPD group. And they also found out that the FEV1 was extremely lower in the TOPD group in comparison to the healthy controls and the COPD. And if you see, the FEC is also significantly lower in the TOPD group, which means that the TOPD patients also have a parenchymal scarring, which results in the decreased lung volumes. But one important thing that has to be noted is the dyspnea scores were found to be significantly lower in the patients with TOPD. For example, they had a higher MMRC and they had lower CAT scores in comparison to patients of COPD, which indicates that they tend to behave more severely in comparison to COPD patients. I'm not going into the detail of the autoimmune response, but what this study concluded in the autoimmune nature is that tuberculosis infection can effectively induce autoimmune responses, contributing to an increased expression of Th1 cells and associated cytokines, which ultimately leads to immune dysregulation. Further, the accumulation of the pulmonary inflammatory response facilitates the progression of the TOPD, and it is helpful for clinical diagnosis and development of therapeutic drugs for this sort of phenotype. So one interesting paper which has come in the year 2023 is to find out the presence of a small airway dysfunction and airflow limitation in patients with TOPD. So this is a large cross-sectional population-based study which included subjects aged 15 years or older with a technically acceptable post-bronchodilator spirometry measurements. So post-TB was diagnosed on the basis of radiological evidence and or medical history, and airflow limitation was defined as a post-bronchodilator FEV1 by FEC, which is less than the lower limit of the normal as per the Global Lung Initiative. And small airway dysfunction was diagnosed if at least two of the following indicators were less than 65% of predicted, which is the maximal mid-expiratory flow or the forced expiratory flow. But however, if they had combined an IOS along with the study, then probably we could have had a better understanding of the small airway involvement in the TOPD group. So what this study found out was the patients of patients with post-TB, they found out that if you go to this part of the column, you can find out that the FEC was much lower in the post-TB group, and the FEV1 was also much lower in the post-TB group, and the FEV1 by FEC was also much lower in the post-TB group. And especially when it comes to the small airway involvement, also you can find out that the mid-expiratory flow rates are also much lower in the post-TB group in comparison to the normal group. And if you move on to the prevalence of airflow limitation based upon both the GOLD criteria as well as the lower limit of the normal GLI criteria, it can be found out that amongst the post-TB patients, there is a higher risk, higher prevalence of airflow limitation in comparison to the non-TB patients who developed airflow limitation. So when it moved to the analysis, it is found out that the post-TB patients tend to have higher degree of airflow limitation, but in addition to this, they also tend to have restrictive pattern also in certain cases, but it is not statistically significant. But the most important outcome of this study was small airway dysfunctions were found to be significantly higher in the post-TB group in comparison to the non-TB group. And even after eliminating the risk factors of smoking, it is found out that the post-TB group tend to have higher degree of airflow limitation as well as higher degree of small airway dysfunction. So this study concluded that the post-TB is positively associated with a pulmonary function impairment and make for a frequent respiratory symptoms, and post-TB should be considered as a potentially important cause of an airflow obstruction and respiratory symptoms in patients coming from areas with high burden of tuberculosis. So when it comes to the treatment aspects of the TOPD, much of the knowledge as we have on date, there is not much difference from the standard COPD management, because the basic principles of the management remains the same, that is symptom control and the prevention of exacerbation. But one important thing to note is when we counsel the patient, we need to be more realistic to the patient, because unlike your COPD patients, your TOPD obstruction may not respond significantly because it lacks bronchodilator reversibility. Therefore, it is associated with a more fixed obstruction. And any patient with a TOPD who has got a symptom of wheezing may indicate that they may have a good response to bronchodilators. One important thing which I would like to stress here is inhaled corticosteroids are found to be associated with higher chance of pneumonia, and extrapolating that data, if you have a patient with a TOPD, then it is always better to avoid an inhaled corticosteroids, unlike your COPD, where you will tend to give more inhaled corticosteroids in frequently exacerbating patients with an eosinophil count more than 300. Whereas in your TOPD, it is better to avoid an inhaled corticosteroids until and unless the patient is also an asthmatic. If not, we generally give a bronchodilator with a LABA and a LAMA, avoiding the ICS, because ICS can cause a reactivation of your tuberculosis. And most of the data we have is for the tiotropium, and some of them are also on indacaterol, which shows a significant increase in the FEV1 by FEC. And in addition to this, one thing that has to be remembered is any patient with a COPD is also at an increased risk of TB. Therefore, sometimes your patient of COPD, if they develop TB, they can have more severe impairment of their lung functions. And there was a threefold higher risk of developing tuberculosis in a COPD patients, and the incidence of the tuberculosis was inversely related to your FEV1, indicating the lower your FEV1, higher is your chance of developing tuberculosis. And COPD patients who develop tuberculosis receive more oral corticosteroids and oral beta agonists. That is why even in COPD, we insist that if a patient develops a recurrent pneumonia, then it is an indication that you stop the ICS. Inhaled corticosteroids use has also been related to a higher risk of tuberculosis, and the risk is more with the use of high doses of inhaled corticosteroids equivalent to fluticasone 1000 milligram per day. Fluticasone salmeterol carries a higher risk of PTB than budesonide formoterol. The possible explanation is that the elimination of the fluticasone is much lower than that of the budesonide. Therefore, the residual time with which it acts on the lung is much more. So there's one study which is called as the ITOP study, which is a pan-India study where post-TB lung disease are associated with PTLD and TOPD. And this study is being done by my dear friend, Dr. Arjun Khanna, and he asked me to share the slide with you. So if you are interested in doing some sort of a study related to TOPD, he wants me to share his email IDs with you so that you can enroll for the study. So to put it into the nutshell, if we move on to the pathophysiological mechanism. So one, there is an activation of your innate immune sensing, then there is an acute inflammation, there is an orchestration of your chronic inflammation, and finally it results in tissue damage and remodeling. So depending on this, people are trying to understand if they can use any of these targets like an antagonist to IL-6, TNF, IL-1R and interferon, or medications which act upon the inflammation like corticosteroids or DMA based and even anti-TNF, or anything that impairs your macrophage activation, or even people have even tried metformin and imatinib in experimental studies, or sometimes people are trying to understand if any antifibrotics can also be used in certain cases of disorders where there is tissue remodeling. But all these things are in the experimental phase, and if you really have to put at this point the certain key messages that you need to carry when you are dealing with a patient with the TOPD is, if your patient is having a tuberculosis, at the completion of the treatment, it is my practice to get a repeat X-ray to see if there is any sequelae of tuberculosis or not. and better to get a baseline spirometry at the end of completion of treatment to find out whether this patient in due course develops a TOPD related changes or not. And let's say that the patient is diagnosed to have a TOPD after excluding the confounding factors like a smoking or a biomass fuel exposure, then I will start these patients preferably on a LABA and a LAMA, and I will try to avoid ICS as much as possible because there is a risk of reactivation of tuberculosis with the use of the ICS. And the most important thing is TOPD patients are more prone to develop recurrent infections because of the structural lung damage. And therefore, in my experience, in certain cases of TOPD with the recurrent exacerbations, I have even tried the long-term azithromycin. But one thing that has to be done while giving the long-term azithromycin is that you need to rule out a prior NTM before starting these patients on long-term azithromycin, because azithromycin is a very good drug which works for the NTM. And another important aspect is whenever a patient with a TOPD develops hemopsis, always suspect a bronchiectasis. And if the patient is not having a bronchiectasis, always suspect a scar carcinoma or an aspergilloma. And finally, if the TOPD patients go on to the requirement of a oxygen requirement, then probably sometimes lung transplantation may come into play, but the effect of long-term immunosuppression for the post-lung transplantation on the reactivation of the tuberculosis is always a questionable thing. So I'd like to end my presentation here, and if there are any queries, we will take it. Thank you.
Dear Vishwesh, thank you so much. This was really an absolutely fantastic talk, absolutely state of the art. You completely gave a perfect overview and everything that we need to know while dealing with a patient of TOPD. As brilliant as always. Thank you so much, Dr. Vishwesh. I'd like to now introduce our moderator, who unfortunately did not get introduced till now, Dr. Nitin Abhyankar. Of course, Dr. Nitin Abhyankar requires no introduction whatsoever. He is the pride of our Maharashtra, fantastic pulmonologist, an amazing interventional pulmonologist, and a wonderful human being, and a very, very dear friend of mine. He's done MD medicine, followed by he getting his European diploma in respiratory medicine, a passionate pulmonologist, multiple publications, multiple pioneering things, and he's the Vice President of Indian Association of Oncology. With this brief introduction, Nitin, over to you. Please take over.
Thank you, Amita, for your very, very kind words and very kind introduction. And let's start with this panel and what, I mean, we have the really privileged and honor to have Dr. Alok Gopal Ghoshal, sir. He is one of the most respected pulmonologists across this country, and he's been a past president of Indian Chest Society. And if I start reading all kind of things about him, I think just the name Dr. Ghoshal, sir, is enough rather than having to read the entire biodata of him. May I introduce the next speaker, which is Dr. Shivareshmi Unnithan. She is the consultant pulmonologist and intensivist in Fortis Hospital, Kolkata. Once again, a ERS fellowship in EBUS Amsterdam in Netherlands in 2018. She is a thesis guide and co-guide in DNP respiratory medicine in Fortis Hospital. And she also is a European diploma holder in adult respiratory medicine from Milan in 2023. Welcome, Dr. Shivareshmi. The next person I have is Dr. Sonali Trivedi. She's from my city, possibly because her workplace is my city, but at the same time, she's the CMO in respiratory medicine in ZNL HRC Bhilai. She's RNTFC medical officer from Varanasi, DNV faculty and thesis guide, co-investigator in Embark India, ISAR studies and TOPD studies, faculty in NAPCON, and co-author in the book Pulmonary Diseases in Women. So welcome, Dr. Sonali. And I think you have worked a lot in CREST and as well as CRF. So welcome to you. And of course, I don't think I have to introduce the last, but not the least. She's the largest of them all. And they said, where does she get time to reply to all kind of questions and, everybody individually. So I said, have you visited the planet called Krypton. So she is the superwoman of Indian pulmonology. So I think that is good enough for Amita's introduction. So with that, I think, am I leaving anybody behind? I think I've introduced everybody. So let's go on to the first question, and my first question goes to Dr. Ghoshal, sir. Sir, I think Vishwesh has done a very exhaustive job, but at the same time, I'd still like you to make it maybe simple or make it more even complicated. But how does tuberculosis cause COPD in your thinking process?
So, good evening, everybody. And it was great, Nitin, listening to the new generation about TOPD. So, what I was feeling throughout, I have seen the change over the last 50 years. So, in 1980, even our predecessors had this idea of tuberculosis associated obstructive lung disease. Practically, this whole idea of present generation of obstructive airway disease like COPD and asthma, they came to the fourth stage after 1980. Before 1980, there were two diseases apart from lung cancer that occupied our imagination and exam hall: tuberculosis and bronchiectasis. Lot of cases. And even bronchiectasis, there is a separate phenotype knowing post-tubercular bronchiectasis compared to bronchiectasis acquired in childhood infection or the congenital ones. So I was thinking as Mr. Sir was speaking, what is the difference? Because that days they were great clinicians, our teachers. They diagnosed obstructive airway disease in severely involved tuberculosis, recurrent infection, etc. But they had no controls. That means when they got an obstructive airway disease and tuberculosis, they didn't differentiate it from smoking, air pollution, infection, and other things. So didn't have the control to get it as a separate entity, number one. And number two, they didn't have the molecular biology of the present days. So we knew, and actually, I don't know whether you know or not, there was a term, coinage, tuberculous asthma. There was a term done by very senior clinicians. That means probably they observed very astute clinicians, but they could not explain everything in terms of molecular biology was not there. Now coming straight, so the question is for all the audience, does tuberculosis lead to obstructive airway disease? The answer is yes. Now, but tuberculosis is a very smart bacilli and myriads of expressions. So practically it is post-tubercular lung disease, that is the apt term, which covers other diseases as well as TOPD or tuberculosis with obstructive airway disease.
Correct.
And there is an interplay of infection, then inflammation, and then immune mechanism. There is a problem there. The bacilli is that smart that it uses even our defenses to its advantage. Everybody knows there is a hypersensitivity reaction from the side of the body which makes it sacrifice the part of the organ to kill the bacilli. The bacilli are not killed, but what happens is destruction of the lung parenchyma as cavitation occurs, caesation occurs. Same thing occurs in the airways, small airways, large airways, all alike. So infection, inflammation, and immune reaction all together they lead to TOPD. And again, TOPD is not exactly COPD because, again, as noted, they are frequent exacerbations. But these frequent exacerbations, I think still they are multifactorial. They are not only due to post-tuberculosis. But my idea is at last that probably tuberculosis, it remains inside the macrophages. Even after spelled cure, we say cure by sputum positivity, lavage positivity, but probably it's such a smart bacilli. It resides there within the macrophages and then ultimately decide the macrophages to run according to their whims, and the inflammation at the molecular level persists even after so-called cure for a long time.
Fantastic, fantastically put, sir. I think it's a very complex topic and complex etiopathogenesis but you have put it as brilliantly as a senior person like you can do that. I'll come to Dr. Sonali and ask her this: is TOPD a different phenotype in our context? Particularly, is it more relevant in the Indian context? So, Dr. Sonali, please.
Thank you so much.
You are muted right now. Yeah, you are muted again. Sonali, you are muted. Yeah.
Sorry.
Yeah.
So thank you, Nitin sir. I would like to thank first the ICS and especially the Amita madam for giving me the opportunity to be on boards on with such a legend persons. So I'm really privileged to be on board with all of you. Thank you, sir. So, Vishwas has already explained the things in a very nice way and in very detail. And TOPD is definitely, it is a different phenotype, as it is because tuberculosis is now recognized as an important risk factor and independent entity for the COPD, for the obstructive airway disease. And in Indian countries, it is very much important because our country, it is a high TB burden country, and more so it is affecting the younger age group. So it is very much relevant because the younger people who are being treated for tuberculosis, they are 2 to 4 times more. There are chances of getting the COPD 2 to 4 times more in those patients. So definitely it is important in our context.
Excellent. Thank you. Thank you, Dr.
Thank you, sir.
Sonali. I'll come to Dr. Amita. And Amita, what are the clinical features which will distinguish a typical TOPD from a COPD in your thinking?
Okay, so thank you, Nitin. First of all, fantastic webinar, wonderful topic, very close to my heart. And we've got the most brilliant faculty. Vishwas gave a very, very good talk. Dr. Ghoshal and Dr. Sonali gave great answers also. So this is a very important question. First of all, history of TB is always present. So the minute we have a patient who's got symptoms like COPD, where there is progressive dyspnea of exertion and there is cough with mucoid expectoration, when the patient says that the patient has past history of TB, please start thinking that this could be TOPD, even if the patient is having additional COPD. There are just a few differences in addition to past history of TB. What is really important is that patients of COPD will either have history of smoking or they'll have history of exposure to biomass, which patients of TOPD may or may not have. Over and above, history of the symptoms of COPD is that the breathlessness is usually progressive. We have found in TB patients that the breathlessness is there, but it is not usually a progressive breathlessness unless they reach a phenotype where they keep on getting repeated respiratory infections. Then the lung function will reduce and then the dyspnea worsens. So patients of TOPD have a history of TB. Patients of COPD have history of smoking or history of biomass exposure. History of patients of TOPD have breathlessness, they have sputum. However, usually the breathlessness is not progressive, whereas in patients of COPD, even after stopping of smoking or stopping of exposure to biomass, the breathlessness is increasing. And on examination, I would say is the key marker over here, because in TOPD, we do not see barrel-shaped chest, we do not see emphysema unless it is a combination of TOPD with COPD, whereas in COPD, if it's not the chronic bronchitis phenotype, then usually always emphysema is present. Over and above, usually in COPD, the breath sounds are almost absent. We get silent chest to decrease breath sounds, whereas in TB, we always get normal breath sounds. In TB patients, or often wheezing is present, which we may not see in patients of COPD. If there is monophonic wheeze, then it is very, very often TOPD because there could be some endobronchial obstruction which could be present in the patient. And
particularly one side getting completely destroyed. Yes, absolutely.
Exactly. So these are the clinical features which will help us differentiate between whether it's TOPD alone or TOPD with COPD.
Okay. Great answer, Amita. I'll come to Dr. Shiva Reshmi and ask her about the PFT characteristics in TOPD. Are they any different? Any intakes on good, old and new, whatever techniques you are using for?
So, Dr. Nitin, Vishwesh has already spoken quite in details about the PFT patterns. But if you look up the studies that you see in the literature, where maybe 15, 20 years of follow-up studies that were done 2 to 3 decades ago, they're all telling us that it's mostly obstructive ventilatory defects. There are some with restrictive and mixed pattern disease. But you and I, we have seen these patients, these TOPD patients coming to our OPD. They are basically long-term follow-up of previously treated TB patients in the, maybe even in the pre-RNTCP era. So most of these patients, they have not been well treated as they would have nowadays. So you do come across these patients who have bronchiectasis, bronchiolitis, that causes airway, small airway obstruction. And these TOPD patients, compared to their only COPD counterparts, they are having lower FEV1 by FVC ratio. You will see they may have restrictive or mixed pattern depending on the number of lobes that have been affected by TB. Moreover, now in our NTEP era, we are seeing relatively younger males. I'm sure you will agree. And these are ones who have had recurrent pulmonary TB, and they are coming back to us with pulmonary function impairment, mostly obstruction with this reversibility. These are patients with lower FEV1, higher airway resistance, which we catch them early with our impulse oscillometry, and we are seeing lower bronchodilator response compared to their only COPD counterparts.
So I think to put it in a nutshell, the younger ones, the recent ones, you will probably be using more, inclining more towards iOS, a little bit of obstruction, and then that would be good enough. Whereas older ones obviously have both severe restriction and obstruction, which is largely not so reversible. So I think if that is what the simple message is.
Yes, absolutely.
Ghoshal sir, I'll come to you again and ask you a very controversial, if I may call that. Does proper treatment with AKT prevent progression to TOPD?
Okay.
Is that a universal statement? Can we make that?
Okay. As Siva was saying, I was just remembering we had a publication in Journal of Indian Medical Association in probably 1984-85. It was about fibrothorax. And most of the fibrothorax were parenchymal and pleural and mostly tuberculosis. And mostly we got there again a combination, variety of permutation combination of obstructive and restrictive defect. Okay. Now about your question directly, whether you said timely antitubercular treatment can prevent it. That is the question?
Yes, sir.
Okay. So if you don't light the fire, there will be no burning.
Yeah.
And if you extinguish the fire in the early stage, there will be little burning.
Correct.
So whether this is true, that even with minimal radiological lesion, there is evidence of obstruction, post-tuberculous. Still, mostly there is a correlation with the extent of the anatomical damage. So early prompt treatment definitely prevents, at least retards the development of post-tubercular obstructive airway disease.
Absolutely. I think wonderful answer, sir. Thank you for that. I'll come to Dr. Sonali and ask her, what are the factors which are associated with increased chances of developing a TOPD, apart from, of course, tuberculosis itself?
Apart from post-tuberculosis. So post-tuberculosis is an important factor because there are patients who are smear positive and those who have extensive disease right from the beginning. And there are less in the patients in whom we find the less radiological improvement. These are the patients who are, they are expected to be going to TOPD in future. Apart from that, the smoking, which is a very important factor for COPD also, it is also a risk factor for tuberculosis as well.
Yeah, absolutely. I think, and probably in females, the indoor air pollution exposure, if that's reducing with the newer things which are happening with, the cooking gas changing and, the hygiene, cooking related hygiene is improving.
Exactly.
But at the same time, I think IAP was an important contributor in females in that particular context.
Yes, sir.
So Amita, I come to you now again, and I think you are the master of this. How do you treat your TOPD patients? The Vishwesh has made so many commitments to it. So you want to counter it or you want to agree with him?
Yeah, so I completely agree with what Vishwesh has said. So basically, the thing is, ideally, when I get a patient who finishes TB treatment, I basically, as a rule, I just don't enter a chest X-ray. Most of the patients who come to us are paying patients. So I always do an HRCT chest because I basically feel that I want to know the endpoint at which I'm stopping treatment. So the thing
Right.
is, when we do basically HRCT chest, that is a baseline I have. And we always do a complete PFT. And we also do impulse oscillometry for these patients. So the thing is that we have actually seen that when you do complete PFT is important because these people usually have scars and therefore FVC will be reduced. And very often the ratio comes normal because of air trapping. So the thing is that very often just by doing a spirometry, we are missing TOPDs, early TOPDs, and doing
Sure.
volumes is actually helping us to know that this patient actually has air trapping. And therefore, I basically feel that doing lung volumes with along with spirometry is a must. And actually, what we have really noticed is that very often post bronchodilator, we are not getting reversibility. But when we are doing IOS, we are getting the resistance dropping by more than 30% upfront in these patients. So I feel that, of course, when all the studies were done, and Vishwe is such a scientific man, so he would always go by all the studies. So this is something which is little different to our country. So of course, I completely agree with Dr. Vishwesh. Basically, we want to start with bronchodilators to begin with. If there's no bronchodilator reversibility on PFT, and we would always prefer dual bronchodilators to single bronchodilator, and longer acting are the best. So using ultra lama would be the best. Otherwise, lama also would be fine. However,
Right.
even if there is no bronchodilator reversibility on PFT, on iOS, if we see resistance of R5 dropping by 30% post bronchodilator, then we actually give, and if there is severe obstruction, if the FEV1 is significantly reduced, then we are more tempted to start steroids earlier for these patients, maybe after 3 months of starting LABA/LAMA. So that is what we are doing. And in addition, we are always vaccinating our patients. So they always get flu shots, they get the pneumonia vaccination. That is very, very important. And if patients have bronchiectasis, then chest physiotherapy started upfront, postural drainage. So either they buy devices like Aerobica, which our Lupin makes, and otherwise basically teach them postural drainage. So this is what is that we are regularly doing. And one very important thing I want to point out about all the studies is that they basically say that when a patient has TOPD, you do a baseline PFT and then you start bronchodilators, LAMA/LABA. And after 3 to 6 months, if the PFT does not get better, then you're supposed to stop it. So this is something that I don't really agree with because often we have seen that the lung function declines in TB with time. So if with LABA/LAMA, if the patient is symptomatically better, then even if the PFT is not better, if the PFT is maintaining, then maybe the patient was supposed to be worse, and with LABA/LAMA, the patient is doing better. So this is what I'd like to say.
Can I ask you one sub question while we are on it?
Yes.
Do you use NAC in this subgroup of patients?
And cysteine. So basically, I think honestly, I'm not much of a very NAC freak. But the thing is, if the sputum is very thick or if the sputum is very, very copious, especially during winters, and it's not just stopping, then I may use for 10 or 15 days. Otherwise, I'm not a chronic NAC person.
Otherwise, you're not a complete
Yeah,
NAC
so I
person.
basically
We'll come to everybody in some way or the other, but I think that's an interesting
and just
sub
one
thought to the
thing,
whole
and one
process.
quick thing, while you said I would rather add an ICS for this patient because although studies are saying all the studies are foreign studies, are the Western studies where they are saying with ICS there's a higher chance of TB relapse or higher chance of pneumonia, but actually in India we've not proven this at all. So I basically feel that if the people are the chronic bronchitic variant type where there's a lot of a lot of sputum coming frequently, I'll be happy to give ICS for 3 to 6 months and get rid of the sputum. And it would help because we get exposed so much to pollution and so much to biomass without our knowledge. So
I think great food for thought, and I think that makes me ask Dr. Shivarishmi the next question. What do you think is the real role of ICS in this? Because that's what Amita has started. So you agree, disagree, you have something else to say, whatever.
Giving ICS on its own in TOPD patients is a bit tricky. I agree with Vishweshwaran, but again, see, where many studies are telling us that ICS users more than 3 months, they have a higher risk of pneumonia or tuberculosis, especially those with using high dose ICS. So this is important, I think. If you are using inhaled corticosteroids, maybe moderate doses will be better. Going up beyond 1,000 micrograms equivalent of fluticasone, that will be put you in trouble.
Yeah,
But
I think, can I just add
yes,
one micro point there? Because we have studied fluticasone propionate in a big way, and the doses were clearly, a little too excessive.
yes.
And I think now we are talking of fluticasone furet. So I think a small dose of fluticasone furet could do a lot of good to at least some of these
Yes.
patients. I'm not saying all of these patients, but some of these patients, definitely.
Yes, you should be careful. For me, I would be careful with a patient who has concomitant diabetes, a patient who is immunosuppressed, just like I would have been concerned with their only COPD counterparts. And just because it is, see, if it is an LTBI and which may progress to TB, or if you are thinking of a relapse of TB, then you just take care of these comorbidities and see if the patient is immunocompromised or properly immunity is maintained. Then there's no harm in giving inhaled corticosteroids. But again, not as single as the what you say monotherapy. I would
Monotherapy.
prefer any day the treatment of TOPD should not be different from COPD. So
Absolutely.
we start with LAMA LABA and then we can add inhaled corticosteroids.
So typically, like from group B, you will go to group E, and in group E, only you in COPD, you will consider adding a inhaled corticosteroid in a similar fashion, possibly those who are recurrent exacerbations. But of course, you will have to keep in mind that the recurrent exacerbations related to infection have to be sorted out from related to
Absolutely.
non-infections. So I think that probably is the differentiator. Yes, Amita, you can comment.
I completely agree with Dr. Sivares. Whenever we are talking about adding ICS, we are talking about low dose ICS. We are not talking about high dose ICS like in asthma. So I'm very, very happy that she added that point, because when I said ICS, I meant low dose, but I didn't really say it. So I completely agree. But I again want to repeat this, that in foreign studies, we keep on talking about ICS having pneumonias. But honestly speaking, in India, it has not been proven. Whether TB is increasing with ICS, whether pneumonia, not a single Indian study has shown this till date. And therefore, I feel that if our patients of TOPD have good reversibility, and after starting LABA, if the improvement is only to a particular level, and if the PFT still shows good reversibility, or after LABA, if iOS is still showing decrease in resistance by more than 30%, then I would definitely want to add small dose ICS. I kind of feel that there is no harm at all, because quality of life is also very important.
Absolutely. Even in the
Yes.
presence of active tuberculosis, it has been documented that
Absolutely.
giving ICS is not contraindicated as long as you are
Yes.
treating tuberculosis properly.
Absolutely.
So I
Absolutely.
think that
Yes.
should be there.
Yes.
So it's I think important to actually tease out that the ICS responding phenotype out of this TOPD patients.
Out of the
Maybe
TOPD,
small airway obstruction, the ones who are wheezy too much, maybe the females who have been exposed.
yeah, or
to
they're
biomass
having simply a coexistent asthma, and the asthma needs ICS in the truest sense. So I think
Absolutely.
that needs to be sorted out. Vishwesh, are you there? Have you joined? I am not able to see him. So if is Dr. Vishwesh down?
I'll just tell him he was stuck in a procedure.
Stuck
I'll
in
just
the
call him.
procedure,
You
okay.
can start. I'll just call
I'll proceed with the next question. I'll come back to him again. So, Dr. Goshal sir, this is the one for you. Is there a higher prevalence of ABPA in TOPD patients in your experience, because there is so much cavitation, so much bronchiectasis, so much colonization with aspergillus? And if you are going to treat these patients, and now this becomes a little more controversial or difficult, that would you be using oral steroids? What dose, what context, and in what way? So what is your strategy there?
That means a whole chapter.
No, sir,
Okay.
but you have only 1 minute.
I'll be no, not 1 minute, but I'll be very brief. But again,
Yes, sir.
first I will again reiterate the idea that molecular biology wise, tubercular bacilli remains in the body. That is the whole concern about TB infection or latent tuberculosis. So chance of reactivation always remains there. Now coming to this question, because our national guideline, they want tuberculosis down, but cannot make it out. It's
Absolutely.
very difficult. molecular
Yeah.
biology wise. Very smart bacilli. Just remains there hidden inside the deep macrophages or somewhere. Now coming back to your question. Actually, our whole idea of aspergillus came from post-tubercular lung diseases. We
Yeah.
all became adults seeing those cases. Aspergilloma was the commonest. See a cavity, show an aspergilloma in MBBS exam to MD exam, even further. So this was the standard, and the DD, whether it can be something else. So practically. Now, this so-called ABPA, most of the ABPA that has been diagnosed in TOPD or post-tubercular lung disease, they are laboratory diagnoses. That means you do total IG, you do Aspergillus specific IG, you get them positive, and just forgive me, there is a publication bias. So taken all together, lot of Aspergillus there, and all spectrum. That means there are Aspergilloma, there is chronic pulmonary aspergillosis, there is ABPA, and even further. So treatment, when you diagnose, I'm coming to aspergillosis ABPA itself. If I have a choice of steroids versus antifungals, it's an individualized decision. It's not a open decision, but that individualized decision probably will tilt me a little to the antifungals rather than using steroids.
Yes.
It is
Yes.
very prudent to be safe rather than sorry. So if I see extensive scarring, and this is a diagnosed ABP and the patient is having symptoms, that means quite short of breath, and then steroids, as Resmi and Anita said, I will go for low dose steroids, inhaled steroids I mean, and I will go for preferably budesonide, not fluticasone, and I will go for oral antifungal. Itraconazole is good, but voriconazole is better. So I will probably opt for the second one.
So thank you for that wonderful answer, sir. Sonali, I'll come to you
Nitin,
and
I'd just like to, Nitin, I'm sorry.
yeah,
I just
please.
want to say that I completely agree with Ghoshal sir, because we all know that voriconazole absorption is much better, oral absorption, than itraconazole. So I agree with sir, as far as if the patient can afford,
If the patient can afford, yes.
voriconazole will be a much better
It's
option.
much better. We have seen very good results.
Yes, sir.
Amita completely agreed in Mumbai scenario. Most of my patients
Afford.
do afford only itraconazole.
Nitin, patients are very prudent. Just I communicate with them, and at least
and then
they'll
they'll
much
go.
refusal.
They'll go to the right way. So Sonali, I come to the controversy again on this. If I have to use an ICS, which ICS? I think I've partially given my bias to it, but I think you can elaborate a little more on it. Which ICS and why? If I have to use ICS in TOPD.
Definitely, it's a very controversial question, sir. And as it has already been discussed, ICS is they are prone for more infections, and I mean they are more prone for tubercular infection. But from my side, if I have been given the choice, I would like to use budesonide, as the fluticasone characteristic of high lipophilicity and prolonged absorption rate and persistent in the airway mucosa, which and it has been shown in the studies also. The fluticasone is more potent immunosuppressant as compared to budesonide. So I would like to use budesonide against fluticasone while using. And because the TB and COPD both shares the to some extent the same pathophysiology, that is the inflammation. So I believe, and I agree with the Amita madam also, ICS does helps in TOPD also.
So you'll be having a subset of patients where you will use it. Your first choice seems to be budesonide.
I want to.
Any controversy between propionate versus furet and where I mentioned it, because I'm little more biased now towards fluticasone furet because the dose is much more smaller, I mean, it is never 1,000. The maximum dose that you are using, even in asthma, is just 200 micrograms. Sir, Goshal sir, I'll come to you once she answers. Dr. Sonali.
Sorry, sir.
I'm slightly more biased now towards fluticasone furoate rather than propionate, because we have used propionate in a very large dose, and that definitely was a problematic territory. But furoate is a different salt and has a different dynamics of lipophilicity, everything else. And the dose is so large, so small that possibly that might be the way out.
Probably, sir, because I have less experience with the fluticasone. So budesonide was always been my choice.
Yeah.
So I have more. I'm more towards.
Here, last 20 years, I've used budesonide, and now I have made a slight shift towards the furoate salt. Sir, Alok sir, you were saying something, please.
Yes. No, what I was thinking, we must present the balanced picture to the audience. So TOPD treatment does not start with ICS itself.
Absolutely.
TOPD treatment is an individual personalized treatment, and most likely bronchodilators would suffice in at least some of the cases.
Absolutely.
Single bronchodilator, you may go to dual bronchodilator, and if you look for recurrent exacerbations, because other clues, eosinophil and things will not be there, then you can go with low dose ICS. That should be the steps.
Very well said, sir. Very well said. So we are never going to forget that the emphasis, real focus, is on maximizing the bronchodilation and giving him the best possible outcome. If that is not enough, and if the patient is exacerbating, make sure that he's not infected again and again, and then only think of giving ICS. And that ICS also has to be considered into the smallest possible dose for the minimum possible duration, if at all. So I think that would be the simple message. Amita, I'm going to ask you this question. Please, the tech team, please let me know when Dr. Vishwesh is there. But in that meantime, I'll ask Dr. Amita, what is your take on using nebulized antibiotics in chronic bronchial infections if they get documented, if they are documented in this TOPD scenario?
Yeah, so wonderful question. So Nitin, usually these patients have gram-negative infections, and whenever people have repeated infections, we would always do a culture sensitivity of the sputum to know what is the sensitivity pattern. And usually the aminoglycosides would be working. So I would prefer to start with nebulized tobramycin, usually 300 milligram twice a day. And I think that would be very, very useful in these patients. Sometimes, a smaller dose also may be given, but I would be happy to give the larger dose only because there are hardly any side effects, not even expensive. However, those very few people who are seriously resistant pseudomonas, where nothing else works except for colistin, then I would give nebulized colistin for recurrent infections. So nebulized tobramycin, nebulized colistin. But I want to also tell our audience one thing, that if there are chronic infections, pneumonia, we can give nebulized. However, if the patient is septic, so if the patient has sepsis or has a severe pneumonia, then the guidelines are that for severe pneumonia or a patient of any kind of infection with sepsis, nebulized antibiotics should not be given, including nebulized colistin. Then you will give IV antibiotics. But if a simple infection, then nebulized tobramycin, SOS nebulized colistin, that is what I use.
Yeah, I think I largely agree with you on most of the points you said, except that even tobramycin is not cheap for majority of my patients, nebulized tobramycin. So it's that change will remain. So Mumbai versus Pune, or Mumbai versus the rest of the country, possibly.
Sorry to, Nitin, I'm just speaking aloud, like nothing to do.
I'm just kidding. Please don't.
Yes, no, but I just somehow feel that it also is a big difference between the way we talk to the patient. Like, for example, I'm going to tell my patient that you take this medicine, in 10 days, you'll be fine. You will not require IV antibiotics. So you will be saving money, and you will probably not require hospitalization. So you will save a lot of money. So the thing is, patients don't really mind it. So I kind of
in fact, I think that same point you were saying was reiterated by Dr. Goshal sir, that how you communicate. I think it matters a lot. So I think we have to communicate.
Cost effectiveness is very important, you know.
Absolutely.
You are getting as against what you pay.
Absolutely. One more question. I think we are still not seeing Vishwesh. I think
I
he
think
seems to
still
be
he
really
was,
stuck.
yeah, because his phone is out of reach, and it was
Yeah.
unfortunate because he
So,
called to
so
say he's got an
we'll
emergency.
carry on with Dr. Shiva Reshmi. This is again little controversial. Would you consider the low dose azithromycin to reduce exacerbations in TOPD? Because we do consider it in Group E COPD
Yes.
as one of the strategies. So, is that a relevant choice for you? Or would you be so scared of NTMs that you would just not do it? Or
No,
would you
no. See, for me, there are some plus points towards giving azithromycin. One is patients who are these TOPD patients who are predominantly having bronchiectasis. I would definitely have a try, especially because there are so many studies that are showing that TOPD patients usually come with more exacerbations. And also, you are seeing a heightened immunopathogenesis of TB in these patients, of COPD in these TB patients. So this lung architecture, the destruction, then these airway obstruction, these are things that are because of this immunopathogenesis. Azithromycin itself has an immunomodulatory effect. We know these TOPD patients have more of CD8 cells in their airways. These are patients who have accelerated tissue destruction. So this azithromycin, because it has a higher concentration in alveolar macrophages, maybe there might be an effect in the reduction of this accelerated tissue destruction. So overall, and more also, just the risk of later COPD development is not just in Mycobacterium tuberculosis, it is there in NTM patients also. Post NTM patients also have around 2 to 3 fold high risk of TOPD. So
Absolutely.
in all these cases, we would definitely see a good result with azithromycin. But yes, it should be provided that these are patients who are not current smokers, and we should be looking at the possible side effects. See the cardiac, we have to take care of the cardiac part, and also we should see to it that these are patients who are not having presently NTM.
Yes, absolutely. Dr. Ghoshal sir, you wanted to say something?
Oh, no, it's okay. Fine.
I'll ask one more question to Dr. Sonali. What is your strategy on when you deal with acute exacerbation of COPD versus acute exacerbation of TOPD, ACOPD versus ATOPD? Do you treat them differently, and in what context, and in what ways?
That AECOPD, it can be either infective or non-infective exacerbations. Likewise, in TOPD also, there can be infective and non-infective exacerbations, because both the patients are liable to expose to the environmental exposure as well as the smoking and other things which triggers the exacerbations. So in TOPD especially, I would like to rule out the reactivation part and the other complications of treated tuberculosis like hemoptysis and secondary infections in bronchiectatic patients, bronchiectasis. So apart from inhaled bronchodilators, that is beta 2 agonist LABA/LAMA, ICS will be, again, it will be a tricky to start with. When there is no secondary infection, when there is no reactivation, then only I would like to add the ICS in cases of AETOPD.
Yeah.
Against the COPD patients.
Correct. So, in an emergency situation, person lands up with a bad exacerbation and is wheezing to glory. Would you just hold back the injectable steroids, or would you give them for a short duration, like what you do in a ACOPD?
Sir, in our practice, we definitely give the injectable steroids first to prevent to settle down the patient. Then only, then further.
Then of course, then that conservative strategy comes back again.
That
so
comes.
as soon as you have stabilized. Yes, sir. Ghoshal sir, the next question is for you.
No, this
okay.
question I was going to answer.
Yeah.
Hello.
Yes, sir.
Nitin?
Yes, sir.
Yes, sir.
So I think Sonal is being a little shy. Not much to differentiate in the acute presentation. We
Yeah.
have to start. And
Yeah.
then you have to tune down or taper down?
Absolutely.
Nitin, can
Yes,
I say
sir. To start with, both can
Yeah.
present us with the similar symptoms. So we have to start.
And very
uh,
frankly, many a times you don't even know whether there is a past history of
Yes.
tuberculosis. When
Exactly.
you are dealing with
So
a
start it
so-called
and
COPD
then
exam.
Exactly.
tune it.
Yeah.
Nitin, can I say something?
Yes, please.
Yeah, I just want everybody to know that inhaled steroids are not so bad as far as relapse of TB is concerned, including our esteemed faculty, because the thing is that abroad there is no exposure to TB. So basically the thing is they are not inhaling TB bacilli and therefore they are worried about, ICS, etc., etc. We are inhaling TB bacilli left, right, and center. So I don't really think that if your patient requires ICS, you should ever hold it up. In fact,
Yeah.
you will hold ICS, patient will get recurrent infections, he will lose weight, his immunity will go down, and he'll actually get TB for no reason. So if the patient requires, please give up, at least unless a proper good study of huge numbers from our country comes and shows that in our country also use of ICS causes TB reactivation. I think till then, if your patient merits steroids, ICS, please give it. Low dose,
So I
but
think, yeah. So the extension of the same thought process, I'm asking a question to Dr. Ghoshal sir. Which is your bigger worry? Giving ICS and inviting tuberculosis reactivation, or not giving ICS and keeping the patient recurrently in exacerbations and coming back to the hospital again and again?
Okay. So it's an individualized decision.
Yeah.
Whether this patient needs ICS, yes or no, I have to decide it first. And if it needs, there is no holding me back. And the criteria have been spelled out before. And I'll try to keep on the lowest dose. And then the follow-up is also essentially clinical. It is not by spirometry. Spirometry helps in the initial diagnosis. I may do after 1 year or 6 months, but that does not deter my practice of monitoring the patient clinically. So again, without ICS, recurrent exacerbation, better not to go in that area. With ICS, under close monitoring, and taper down, we frequently taper down. Actually, the sort of smart concept we use with our patients, even those who are not on this exactly this combination.
Perfect. So I think I think that's you can say an astute clinician and most probably a politician in the making. So perfectly politically
Making
correct. Or already an established politician. I don't know that, sir, in Kolkata. What is your status? And please don't take my comments seriously, sir. Amitav, one question for you is how often do you recommend surgery to reduce long-term consequences of TB and which scenarios? For example, I mean, just, I have seen my army guys in AFMC. If there's an upper lobe clear-cut destruction, they'll simply just, just one exacerbation and they'll just get rid of the upper lobe. And of course, I mean, the army thinking is different from the conventional civilian thinking. So what do you think? Where do you subject these patients for surgery? In what context?
okay, very good question. I think this is fantastic. So the thing is that, there are specific indications. So if the patient has MD or XDR TB, and even after completing treatment, if the patient is left back with a big cavity, or if there's a huge amount of destroyed lung where you're not sure if the medicine were reaching or not. So if it's a very extremely resistant disease where a cavity is left back, then I may recommend a lobectomy, because if the patient gets a relapse, we may not have any medicines to give. That is one. The second thing is that if the patient gets life-threatening hemoptysis over and over, and you basically ruled out, you've tried bronchial artery embolization, you've tried all bronchoscopic stuff, and if that is not helping, then you may recommend lobectomy or pneumonectomy if it is like a destroyed part, which is the cause of hemoptysis. Of course,
Absolutely.
post TB, if we get aspergilloma in a TB cavity and they're getting hemoptysis, then also because they have so much of collateral circulation, usually bronchial artery embolization may be done at the time of emergency, but elective surgery is required for them. Hi, Vishwesh, good to see you. Yes, and if the patients have bronchiectasis and they get repeated infections, or if they have a destroyed part of a lobe or a lung because of which they're getting repeated infections, then lobectomy, pneumonectomy, provided the underlying lung function is good enough to tolerate the surgery. These are the times when I would recommend surgery in a patient of TB.
Fantastic. I think very, very, very well put, Amita. I'll ask one question to Dr. Shiva Reshmi and then go to our main speaker, Dr. Vishwesh. So, Shiva, do you think that that COPD-I is good enough terminology, or we should call it TOPD? Do you need a formalization of the word TOPD, or should we do it in India from the Indian context? What
Yeah,
is your
so in this present Atmanirbhar and Make in India era, see, India has the highest burden of TB in the world. So automatically TB associated COPD patient burden will be significant here. Again, our COPD population is also growing rapidly. So, and here, ironically, the number of studies on COPD from India is appallingly low. So, when you want to define a disease, you would like to know whether, if it is associated with TB, when does this occur? This is one question you would like to answer, because you know that it is a heterogeneous, the variable period of occurrence of pulmonary impairment throughout the TB. This one, it could be during the TB disease, it could be maybe years after the completion of the treatment of TB. This is one thing. Again, you want to know whether this is a distinct clinical entity, which it is, because you know the demographics is different. These are patients who are coming with more bronchiectasis, so they have more hemoptysis. Their bronchodilator reversibility is lesser. Their the airflow limitation may be same as the COPD, but the pack year smoking is lesser. So you know that the association of tuberculosis with airflow limitation is much more than smoking with airflow limitation. There are plenty of studies. Then why don't we come up with a particular term? Why do we sit with TB associated COPD, or maybe tuberculosis destroyed lung with chronic airflow obstruction? I saw one study that showed this. They have, at least Gold has come with COPD-I. Let us come with COPD-T.
Yeah, I would at least go to that extent of calling. So TOPD may be a bit too advanced, but COPD-T is, I think, good enough to start with. As I say, in fact, one of our panel, one of our audiences has made that comment, Dr. Tridip Chatterjee, saying that sequelae are different from TOPD, and I think we have already explained a lot about this in the due course of time. So I think that's not a problem. Vishwesh, are you there?
Yes,
We have reserved all the difficult questions for you. So you better be ready for at least I'll start with the most difficult ones, or the ones which I am not really practicing. What is your take on spigots or walls, etc., when you managed TOPD in a select situation, wherever you want to really collapse that given lung? Given part of the lung, of course, not the entire.
Sir, to be very honest, they all have only limited role. Anyway, we don't have access to valves in India as of now. So the only occlusion device you have is the spigots, which are nothing but silicone plugs. So I will share one of my experiences which I had. So one patient we had who was a post-TB patient, and the patient came to emergency with a massive hemoptysis. So we did a intubation, we secured the airway. So we wanted to take him directly. He was having a cavity onto the right upper lobe, along with the TOPD was also there. So both parenchymal and bronchial involvement of tuberculosis was there. So we want to immediately shift to cath lab, but unfortunately there was a cardiac procedure going on. But he kept on bleeding continuously from that part of the lung. So in that case, what we did was, still we were able to shift him to a cath lab. We used a bronchoscopy. We took those spigots and we selectively occluded that portion of the lung from where it was bleeding, so that we were able to buy time. Later, we did an embolization. And in this case, it turned out to be an invasive pulmonary aspergillosis in a patient with an old pulmonary cavitary disease. So this was one instance where these bronchoscopic interventions really helped in buying time. Apart from that, the most of the times where we actually use these spigots for a TB patient is then they come with a TB BPF. So many a times what happens is, tuberculosis being a bilateral disease, sometimes they will have a chronic BPF where they will not be a surgically fit candidate, because many a times the anesthetist gives extreme high risk and the surgeons are also little wary of
taking such patients on table because they know that even if they close the BPF, they may not be able to extubate the patient. So in such cases, what we do is we go inside with the bronchoscope, selectively occlude with the Fogarty balloon to see from where the leak is occurring. And once we know that from particular subsegment the leak is occurring, we go there, put the spigot in place, and then we put a glue and come out. So basically, either for dealing with a refractory BPF or for dealing with a hemoptysis, these spigots play a role. People have tried using valves in the Western countries and even in some Southeast Asian countries for BPF closure of post-TB cases with valves, but unfortunately, we don't have access. And even if it is coming, it is going to be exorbitantly priced. So we don't know whether until and unless you have a universal insurance, it would be a viable option for India. So these are the scenarios where spigots may help in certain extent. But apart from that, per se, for TOPD alone, where we speak about obstructive lung disease, there is literally no.
Really deserves it, yes. In the truest sense. Trideep has asked a little complex question on increased FEV1 decrease. That means a significant reduction in the FEV1 post-TB patients. A major number of patients would be a good idea to do an IOS in most patients after full AKT treatment, especially if there are some fibrosis seen on X-ray or the patient keeps having some clinical cough, etc. Because once you are sure that you're not having infection. So Amita already said she would do the volume studies and IOS both, isn't it? So I think I will also go the same way. Any other thought processes on this? I mean, are we really biased toward volume studies or iOS one way or the other? I don't think I'll do both most probably, not only iOS.
I'll just add on. So basically, a very interesting question asked by Dr. Trideep. And for the benefit of those who may have joined later the webinar, I just want to say that normally when the TB treatment is over, let's do not just a spirometry, let's do a complete PFT, at least do lung volume so that if FVC is reduced, we come to know if at all there is false normalization, if there's, air trapping, so that lung volumes would help. And what we have found is, because one of our students' thesis topic is iOS PFT in various disease conditions, we are finding no bronchodilator reversibility on PFT, but we are finding very good reversibility on iOS. So we are doing iOS upfront also. And then we are starting LAMA-LABA for these patients. But, after 3 to 6 months of treatment, if they still have sputum production, if they are still breathless, etc., then we are happy to start low-dose ICS for them, and they are actually getting better. So I agree. So this is the thing, that it would be good to do iOS according to me, because often bronchodilator reversibility is only being seen on iOS study.
I think
spirometry lung volumes, of course.
This is one more, I'll ask maybe Dr. Ghoshal sir. This is question from Dr. Ajay Kumar Srivastava, and he's saying, is the spirometric intervention same for COPD and TOPD, or is it a little different? I mean, spirometrically.
Okay.
iOS is an added disruptive technology. So we take that as an add-on rather than, destructive or disruptive. It's an add-on, but alone, spirometry alone or volumes alone, would it be different for COPD or TOPD?
No, practically what we do, we extrapolate the gold criteria to TOPD as well.
Absolutely.
So there is no separate established criteria for TOPD. We just interpret them. But again, I say it has to be clinical plus spirometric variables altogether, not a single value. But usually it is the extrapolation of the gold criteria.
Perfect. Three questions in fact from Ajay Kumar. One of them is, I think it's been already answered. Can we use ICS in TOPD patients if there is a severe obstruction and a good reversibility? Both are present. And if yes, then how long? I think this has been mostly answered. Maybe the duration can be answered a little better. I don't think these people are going to get better forever after 3 months of therapy with ICS. So if I continue with it, I'll probably continue with the lowest possible dose that the patient is.
Absolutely.
Nitin, I just have a suggestion. Nitin, 1 minute. Basically, Nitin, normally when we are starting the webinars at 8:30, we have lots of emails which have come from ICS members that they work till very late and they are able to join only at 9:15. And therefore, they have requested that even if certain answers are taken in the lecture or they've been answered, if people are putting up, then do answer. So I feel that maybe whatever things we've already discussed, we could take those questions, of course, in short, because these are the people who joined later and missed out, but they want to still
Okay.
regardless join. And they are
No
sending us
problem.
emails to say that please take our questions.
Yes. So I think the other part which has been asked to Dr. Sivarashmi mainly by Vijay Kumar is how to prevent TOPD in patients. How do you prevent? Oh, wow, fantastic. Great question.
This is
If Sivarashmi answers this question, then well, I mean, she's set as a ultimate.
I wonder why
person.
this question is targeted only to me. It should have been to Dr. Ghoshal, because this has to be answered with a lot of experience. For me, I would definitely see, if I see that if this TB patient, TB patients we are also treating, and we are seeing, if we see there is a good extent of lung, what do you say, involvement, and if you see the duration of the disease is slightly higher, or if you are looking at a patient whose age is above 40 years, then probably this is one way of, and if the patient has not been able to take the treatment properly, then probably these are the risk factors you would look for and think of. These patients might just end up having TOPD. I didn't. This is my take. I would rather have somebody else.
Yeah. So,
put in
Ghoshal sir,
some.
can we have your comments on this also? Because I think this the experience matters in this.
What is the exact question?
So how will you prevent TOPD in general?
Okay. By treating tuberculosis at the earliest.
At the earliest,
And
yes,
by
I think.
treating comorbidities. Actually, TOPD is frequently have comorbidities: smoking, low socioeconomic, air pollution, recurrent infection.
Undernutrition, malnutrition, both,
yes.
both
So
combined.
treating tuberculosis at the earliest, because there is an anatomical correlation on the positive side, that is extent of the destruction follows by TOPD, though it is true that minimal also can have TOPD later.
Dr.
Nitin, I completely agree with sir. It is, really spot on. And I just want to add that, please, because we are in Mumbai, you just don't have to start it immediately. You have to also start correct AKT. You have
Yes,
to
true.
upfront for the drug sensitivity, and you have to give the correct doses. Don't underdose your patient, and don't empirically start assuming this must be sensitive TB, because then you are allowing TB to grow more and more chance of TOPD. More
But must follow NTP, please. Must follow NTP.
Absolutely.
Absolutely.
In fact,
Absolutely.
I just recall a study that I came across, that the later the TB ATD has been started in these in patients, they are the
Definitely.
patients who have actually ended up having TOPD.
Definitely.
Absolutely. The typical, scenario where you have to start an antibiotic within 8 hours was the thing. Now they are talking of the 1 hour kind of scenario at the earliest, ASAP. So in a pneumonia cap, we are saying ASAP. So I think ASAP is the right word, but ASAP doesn't mean empirical. It means with some evidence as far as possible. And GeneXpert or CBNet has definitely changed that scenario. We are actually getting a very early diagnosis of active tuberculosis. Pulmonary, at least, we are definitely getting it. Dr. Sushma Dugar's asked a very interesting and controversial question. What is the role of probably oral steroid? That's what she means in TOPD. Is there any role, and do we use them? Yeah.
So
Anybody
Nitin,
on this?
okay. Okay, Dr. Sivaras, we can take it. Yes,
No, please, Dr. Amitabh, you please.
I basically feel that if there is an acute exacerbation of TOPD where a patient is wheezing away, hypoxic, breathless, then like we give steroids for oral steroids for 15 days, we would give. There's no harm in giving it. But otherwise, we don't routinely give long-term steroids unless the patient is hypoxic, is in type 2 respiratory failure, and is requiring small amount of steroids, to prevent NIV, etc., etc. Otherwise, 15 days of oral steroids during an acute exacerbation is absolutely justified. In fact, please don't avoid using oral steroids when required, because you are just, as I said before, patient will be more sick, worse nutrition, worse immunity, and TB relapse. So 2 weeks of, like the way we would have treated COPD, oral steroids is no problem.
So that means acute, yes, no role in chronic maintenance therapy.
Yes, absolutely.
Absolutely. Unless until you're really, really up against the wall.
We are often getting these completely respiratory cripples because of extreme TB, in which they are not only oxygen dependent, they are also on NIV. And we are giving them a small dose of steroids, 5 mg Vislone or something, to just keep them going.
Yeah,
But
I mean,
intubation-
and a lung transplant is more or less ruled out. So
Yes.
more or less.
No, yeah. So lung transplant, while they are awaiting, also we are giving a small dose like 5 mg, which is not kind of coming
Which is
in.
not going to kill.
Yeah.
As
But-
long as you are watching them carefully, of course. As sir rightly said, it should not be a standard of care kind of a recommendation for everybody. Very select population, absolutely up against the wall, and just to keep them going with all the supportive care that is possible at home.
Correct.
Vishal, since Chauhan asked you a question about roflumilast. Anybody using roflumilast in this group? I haven't used it.
Should we ask Vishwesh? Because Vishwesh is now with us. Vishwesh?
Vishwesh, yes, Vishwesh,
Did you get any
any thoughts on the roflumilast in this group? We have talked on azithromycin, but
Okay, Vishwesh probably had to again. So,
yeah, I think
So,
Dr. Sonal, you can take that. Or
can I take it?
Yeah, you can take it.
So one of the side effects of roflumilast is weight loss. You know, a very important side effect of roflumilast is weight loss, and our TB patients are often undernourished, etc. And you know, we have been using theophylline so nicely, and we don't find roflumilast to be a wonder drug at all. In that, that's the reason roflumilast didn't really do well. So I think it's a fantastic question. But if required, I'll be happier to give an oral theophylline over giving roflumilast because of the side effect of significant weight loss.
Yeah,
It's
in
a
fact,
good
I
thought,
find
but
it
no
very.
evidence actually.
In
Should
fact,
not be extrapolated from
Exactly.
COPD to TOPD.
COPD. And they lose so much appetite with roflumilast.
Yes,
Some of
lot of
Yes.
loss of appetite.
Not many GI effects.
Yeah, so weight loss is
Do you have any take on this roflumilast in TOPD?
Vishwesh.
Regarding roflumilast, actually there is no role of roflumilast as of now in TOPD. In TOPD, if at all, there is only one proven benefit they have found out with tiotropium and indacaterol. But we still extrapolate the use of LABA and LAMA, a combination of LABA LAMA in TOPD. Apart from that, even the role of ICS is also very controversial because inhaled corticosteroids can also cause the reactivation of tuberculosis. So we generally try to avoid even inhaled corticosteroids in TOPD patients. And definitely roflumilast, we don't have any evidence. And even in COPD, it worked only for very small subset of patients who had recurrent exacerbations. And in best of our experience, most of us would have realized that it doesn't work uniformly in all patients of COPD. But one thing of late, what has actually helped even in these patients with TOPD is the long-term azithromycin because of anti-inflammatory action, which there is no proven studies of it, but we have seen
clinical experience is definitely there.
Yeah,
Yes.
because these TOPD patients also have bronchiectasis component. So definitely this long-term azithromycin, which has proven to be beneficial in a bronchiectasis, might also help in your TOPD patient. But one caveat is, before you start azithromycin, you need to make sure that the patient doesn't harbor an NTM infection, because TB patients are prone to get NTM, and if NTM is already there, it might be counterproductive for your patients if you are starting on long-term azithromycin. So
then you are probably making it worse.
Making it a drug-resistant NTM, true. So we generally don't use it.
So Ghoshal, so this is a specific.
Between Vishwesh, while you were not there, we had a long discussion about ICS in TOPD, and all of us, there's no harm.
This is a question which is coming from one of the audience, and I'll in any case it will go to Dr. Ghoshal, and Vishwesh also will comment on this. Dr. Venugopal asked this question after the Indian EMBARK study. There was a huge comment saying that in India, a lot of pulmonologists treat bronchiectasis with ICS. There are many reasons for starting ICS, like eosinophil count, reversibility, post-bronchodilator reversibility, and bronchospasm, presence of it. All worry about relapse of tuberculosis. I would like to ask Professor Ghoshal to comment on this. This is Dr. Venugopal, sir.
Okay. So it comes ultimately that there is overuse of ICS and there is underuse of ICS as well. There is no doubt about it. And also bronchiectasis itself is not a candidate for ICS, but in India there is frequent overlap as well.
Yeah.
So whenever you think of ICS, the criteria must be there, clinical and lab, simple, eosinophil 300 or above, and then bronchodilator reversibility. And if you think that there can be an overlap with asthma. So ICS is not the recommended drug for bronchiectasis. Actually, bronchiectasis honestly depends more on supportive therapy and respiratory physiotherapy rather than on any drug.
Totally.
Bronchodilators do help, and probably NAC helps, but not ICS. So just comment is that EMBA study showed the trend because there is a lot of obstructive airway disease and asthma is very underdiagnosed in India. So probably that interpretation may be different from other side.
Yeah. Wonderful comments. I think that makes it very solid. Vishwesh, you have any other take on this, or I'll ask you another question? There is another question
The
waiting for
only
you.
one is where your ICS may really help us when you're dealing with ABPA. So when you have an allergic
Done.
bronchopneumonia.
That we have discussed actually.
Yeah, we have discussed that. Yes. So in ABPA context, yes, possibly rather than using a large dose of oral steroids, I would use maximum possible dose of ICS along with an antifungal. So I think that is a very right way of doing. Another question, very interesting one, which is Vishal Sinha Chauhan asks is, any specific criteria to use ultrafine particles in these patients? I mean, we have some ultrafine particles, for example, beclomethasone now. So very interesting question. Any experience on this?
So if we go by the TOPD, there in the talk also there was one study, but they didn't use IOS. They just used the PFT with the mid expiratory flow rate to find out if small airway component was there or not. And they found out that small airways are more significantly involved in TOPD than in COPD. So if we go by that, then there can be a role of the ultrafine particles. But again, ultrafine formulations contain steroids. So whether it is going to really help in your patient with a TOPD is a questionable thing. So as on date, we don't have any evidence to suggest it. Still, we use only this LABA-LAMA combination.
So, I'd like to
Amita,
say,
you want to add something?
I'm adding on. I agree with what Vishwesh said. I want to just add on that we need to understand that most of the obstructive airway disease because of TB is because of obliterative bronchiolitis. It's basically bronchiolitis first, and it is always small airway first, and then it's large airway. So the thing is that ideally speaking, ultrafine particles would definitely help. And I personally feel that instead of upfront starting them, what I would do is that a baseline PFT IOS, and then if there's reversibility, then you start with LAMA after 3 to 6 months. If the patient is still getting recurrent infections, lot of sputum, still breathless, I will add ICS first. And after that, also if the patient is still symptomatic, still breathless, then I will definitely give a chance to the combination Nevioli, which is available, ultrafine with ICS. And the thing is that we have quite a few patients like that, probably because I end up seeing a lot of TB cripples. So we've actually used and we've actually documented improved PFT. So I basically feel that ultrafine particles could be used in this order, LABA-LAMA, only reversibility, then ICS.
Yeah, and now we have a tool called iOS, which will actually document that also. So I think there could be some justification in what we are doing, I think, in addition.
Absolutely. I think, Nitin, you and me are routinely doing iOS.
Absolutely. We do it. iOS as a standard of care for the spirometry goes along with iOS. It is never done in isolation now. All our patients.
Like cough variant asthma, where PFT never shows reversibility, iOS always shows reversibility. It's just.
I think the message that we should put across is that it should not be a blanket therapy.
It is not a blanket
therapy. So we just
LABA is a blanket therapy.
We have to justify our inhaled corticosteroids for TOPD.
Totally. First of all, we have to justify the ICS. Then we are talking of ultrafine particles. We are not talking of ICS as a standard, ultrafine ICS as a standard of care at all. Not at all. Another interesting question, I think if Vishwesh is there or Amita can answer this, management of a localized wheeze because of a bronchial constriction or a pressure by enlarged lymphadenitis. I think this is not really TOPD. This is possibly more of a endobronchial tuberculosis obstruction related. So Amita can also take that, or Vishwesh, if you are there, you can also take that because you are an IP guy.
Okay.
Yeah, Amita, you can take it.
Yeah, so basically the thing is that if it's pressure by lymphadenopathy, then usually it would be right middle lobe bronchus. Right hilar lymph node will get enlarged, will compress the right middle lobe, and the function will hardly get involved. So I will not even bother to do anything. And also, if it's V's, then it depends on where is the endobronchial obstruction. So if it's involving the large bronchus, like right main bronchus or bronchus intermedius, then or left main bronchus, I may want to do bronchodilation, etc., balloon bronchoplasty, etc. But if it's isolated right upper lobe bronchus, which is narrow and because of which there's monophonic wheeze, I will just leave it alone because rest of the lung will just take over. So just because we see bronchial obstruction doesn't mean, we have to go in for it. It has to cause significant breathlessness and diminished lung function. Otherwise, you don't need to do anything.
Yeah, I think
Nitin, there
Adib,
was a name to this long back, AP tuberculosis.
Yes,
Lymph
sir.
node compression with the bronchus and giving consolidation and collapse, not interluminal. There was a
correct.
name to this, AP tuberculosis.
No, sir, actually, it's Frock syndrome, right middle lobe collapse because of enlarged right hilar lymph node, which is seen in children. It is known as Brock syndrome. So
I think we are more or less at the end of it. Dr. Rida Khan has asked multiple questions. Most of them we have answered. I'll take one question and let everybody comment on it. Can you please tell the PFT findings in TOPD patients? I think that has been done.
That
And
is
are
all.
there any specific? The most important question is: are there any specific guidelines for TOPD diagnosis? So one by one, and I think then we'll go to the concluding remarks. I don't think I have answer to this questions. Particular, I don't think there are any guidelines. You
correct.
have,
Can I
you have
answer?
to, yeah. Amita, you can.
Yeah, so Dr. Rida, it's a fantastic question. So unfortunately, there are no guidelines. Maybe, ICS should get together, get an expert group. So Dr. Ghoshal is here. So we should maybe make guidelines about
That's
different.
what I was thinking, because we need not get multiple speakers. The answer is no. We don't have any guidelines for TOPD because actually that entity still doesn't have a definition.
Yes.
To have a guideline, we need to have a definition. Easy definition actually.
That formal definition will make a
Yes, and actually it is not that difficult. Evidence of past tuberculosis, evidence of airway obstruction, and exclusion of other causes. These
Exactly.
three together.
Yes,
Perfect.
I think wonderful discussion I have had. So I'm going to request each of you, starting with the senior most, Dr. Ghoshal sir, your concluding remarks, then Shivareshmi, then Sonali, and then finally Amita. So we'll start with Dr. Ghoshal sir because senior most. So your concluding remarks.
I support NTP and tuberculosis preventive therapy in spite of the controversies. And TOPD diagnosis, basically clinical with the help of spirometry and IOS definitely. Again, we should have evidence from our side, India, IOS in tuberculosis, TOPD, and the treatment is clinical as far as possible with bronchodilators, with ICS low dose needed when there is a recurrent exacerbation.
Wonderfully put, sir. Wonderfully put. Dr. Shivareshmi.
So from my side, I would say that considering the fact that we have separate demographics, a separate, the natural history of this disease of TOPD, definitely we have to look at a new definition, new guidelines, as the audience also wants us to think about. And the fact that we do not know the total number, the exact number of TOPD cases, the percentage of our TOPD cases. So we need more studies related to this disease.
Sonali.
So my take is early intervention, early detection of TB, and the proper treatment as per the NTP guidelines will help to prevent the TOPD. And definitely the guidelines, as already Shivareshmi said, I am also in favor of putting new guidelines and new terminology for TOPD.
Before I come to, thank you for that final comment. And Amita, before I come to you, let me announce that it is 1,547 logins till now, right now. It is still continued. So those many have continued. So it
Wonderful.
might be a little higher before. Yes.
And Nitin, I have more information. We have 48 questions. I counted each of them.
I couldn't take each and every because there
Listen,
was
there
some
are many more
overlapping. So
questions actually,
please
but we can't-
pardon us for that. If I have
there are
missed on
many
somebody,
questions.
yeah, my apologies to them.
No, so okay, I just want to say that fantastic moderation by our Nitin. It was just so state of the art. Fantastic job by our dear faculty. And I just want to basically say that please diagnose TB at the earliest. Please treat it effectively with the correct AKT, which as per the sensitivity patterns, give the correct dose. After your patient's treatment is over, please do a spirometry, and if FVC is less than 80%, please do lung volumes also, and also do an IOS. In addition to LABA, LAMA, SOS, ICS plus minus, please give vaccinations to these patients. It's very, very important. And please use either physiotherapy or the devices, to get rid of secretions for those people who have bronchiectasis. And if it's a destroyed part of the lung, which is chronically infective, then doing resection of that part, to prevent further infections would be worth considering.
Very, very, very well put, Amita. And thank you everybody, the entire faculty, my panelists. I mean, Goshal sir, Shiva Rashmi madam, Sonali, Amita. I don't have to thank you. You have to thank me. So the other way around. And Vishwesh, of course, who did a wonderful job of delivering such a wonderful talk. So it was a great pleasure for me to moderate this session. And with that, I think it's a goodbye from our side.
Good evening, everybody.
And
Good night.
a big thank you to our audience, 1547 still logged in. A big thank you to Team Lupin, of course. In fact, Chitra Chand is over here. Thank you so much, Team.
If you want to say something, you are
Academic
welcome.
partners. Thank
I
you.
enjoyed it very much.
Yeah, I think
Thank you, everyone.
faculty was super. And
Thank you so much.
yeah.
Thank you so much.
Thank
Thank you so
you.
much, sir. Good
Bye.
night.
Bye.
Good night, sir.
Thank you so much. Dr. Amita, thank you very much.
No,
And
no,
Thank you,
Dr.
ma'am.
Nitin, great.
I think each of you all were fantastic, amazing stuff. Really excited.
Thank you
Wonderful.
so much.
I
Really
mean,
enjoyed.
honestly, not had these kind of comments, but then I stopped putting comments. I was in the OPD. Like every group is flooding with comments the minute I put the picture. So I think it was great.
Yes, sir.
Good night.
Good night.
Are we offline?
We are, I think, offline now.
Are we? Then
Thank you, Arun.
are we offline?
So from here, I'm ending this meeting. Thank you.
I don't know what they said. Are we off?
We are offline now. She's ending the meeting.
No, but we
Yeah,
are talking. Just wait.
Oh, okay.
Yes, yes, ma'am.
I know everybody's hungry. No, but listen, I think I think fantastic. I think, Sonali and Sivrasmi were too good.
Thank you,
Really,
Thank
ma'am.
you. Thank
so
you.
much on the point. I just loved it. Nitin, of course, too good. Even Dr. Ghoshal was very good. Huh?
Yes,
Yeah,
ma'am.
absolutely.
Dr. Ghoshal has a
No,
absolutely
he's
different take
really
about
a
everything.
out-of-box thinker. Very
Yeah,
good.
no, I
Very
loved the way he spoke. He was very good. No, but both our girls were brilliant. I mean, you all were
absolutely.
rocking. I just feel that,
Thank you.
listen,
Thank you so much, sir. Thank you.
So the point is, when you are around, we have to be at our best.
Yes, ma'am. That is the beauty.
crazy. I got a very bad ICU admission. तो मैं तो पूरा वाट लग गया था मेरा, so then, but it was okay. We managed, I think. So,
Yes, ma'am.
but
But
Nitin,
when you have Dr. Nitin moderating you, you really can't do anything more
Nitin,
than doing
Nitin, you
better.
are fabulous, Nitin. Too good. By the way, Nitin, कितने questions HRCD findings to look for in patients of TB?
Yeah, I missed some, but I think it's
Difference between the
impossible to
sympathy
cover
of
everything.
TB, कितना questions है?
Yeah.
No, but I think the audience also paid attention, na? Depending on
Yes.
what we are answering, they're asking further questions, which is too good.
Yes, ma'am.
What is
Wonderful.
steroid dose in a patient of TOPD with ABPA with duration? सब लोग सुन के अच्छा क्वेश्चन डाला है यार.
Interesting topic, ma'am. Really interesting.
Yeah, it was really. And this is something everybody wants to know also about.
If
Yes,
it only
ma'am.
decide to
And I think, everybody has a different set of
experience.
experience, different set of exposure. For example, Amita would have so much MDR, XDR with her. We have a drug sensitive tuberculosis, but we still have a lot of damaged lungs because they come from peripheries to us. So,
Yes.
so a lot of delay and late diagnosis. So there is a lot of destruction of the lung, even without drug sensitive tuberculosis. So I think that's another territory altogether. So everybody
That's
has
what
a-
I said, na? ये pre-RNTCP era wale hai.
Yeah.
Those who
Yes.
have come.
But
We still are in that area.
We in primary MD are so much, no?
Though it is much better today, but see what we are seeing as experts is something which was cooked up 10 or 15 years ago. So I think that's the time. It is like that.
And so I am being, sir, working in a steel plant near industry, because it is a SAIL hospital, Steel Authority of India hospital. So we are getting a lot of patients from there also, because there is the environmental and occupational exposure also, sir.
Exactly.
Guys, while you continue, do I have your permission to take leave?
We also going.
No, we are also going.
Okay, thank you so much. Bye-bye. I hope you all enjoyed.
No, it was fabulous.
Good night.
Enjoyed and
Thank
amazing
you.
numbers till the end. Thank you, Team Lupin,
Yeah.
as always.
Thank you. Bye-bye.
Thank
I'm
you.
going to think about TOPD guidelines. Just 1 minute. Girls, wait. Within wait.
Yeah.
So I'm just saying that I'm going to talk to ICS because I'm the TEI. Like I'm in charge of all the guidelines and all. So actually, we were initially thinking of making shingles ka vaccine ka guidelines, but I'll just put it on the side and let's just consider TOPD. I'll see if there are enough studies. No, then we will actually make TOPD guidelines.
I think
and
we
our
could
entire
come up
panel.
with,
And so a promise that our entire panel of 6 of us will be on the guideline making committee if we take this up.
Okay, great. Thank you.
Yeah, no, because I
Sure,
think
I would like.
yeah,
Yes,
and I
ma'am.
think everybody did well, and I love the questions. Also means people were listening to us. Matlab vasool. Yeah. 48 questions is huge, yeah, really huge. Okay, thank you. Chalo, bye.
Thank you. Bye.
Bye
Good
bye.
night.